A synoptic pathology report for gastric cancer dissecting the details of gastric adenocarcinoma. Welcome to our podcast, where today we delve into the intricate world of gastric cancer pathology. Our focus will be a comprehensive synoptic pathology report, presented in a narrative format designed for clarity and depth. Join us as we journey through the key findings that guide clinical decisions in the management of gastric cancer. Patient and specimen overview. We begin with the patient's background. The individual, John Smith, underwent a surgical procedure known as a distal gastrectomy, which included the removal of regional lymph nodes. This operation was performed using a technique called Billroth reconstruction. The specimen was received on the 10th of November, 2023, and the case was overseen by Dr. Lee. Clinical history and diagnosis. The patient's history includes a biopsy-confirmed adenocarcinoma located in the antrum, which is the lower portion of the stomach. Notably, there was no prior therapy aimed at shrinking the tumor before surgery. The preoperative diagnosis was gastric cancer, and following the procedure, the diagnosis remained invasive adenocarcinoma of the stomach. Macroscopic description. Upon gross examination, the specimen consisted of a segment of stomach measuring 12 cm along the lesser curvature and 15 cm along the greater curvature. An attached omentum measuring 10 by 8 cm was present, along with regional lymphatic tissue. The tumor was identified as a firm, ulcerated, and elevated mass situated in the antrum, 3 cm from the pyloric ring and 2.5 cm from the duodenal margin. The tumor measured 5.5 by 4 by nearly 2 cm. The surface of the stomach that covers the tumor was noted to be retracted and firm, with a pale appearance. Importantly, both the proximal and distal surgical margins appeared free of tumor on gross examination. Microscopic findings. Microscopic evaluation revealed that the mass was made up of an invasive adenocarcinoma, which varied from moderately to poorly differentiated. The cancer had penetrated through the muscular wall of the stomach into the fatty tissue just beneath the serosal surface. The tumor exhibited a combination of gland-forming and signet ring cell features, the latter making up approximately 20% of the population. A dense fibrous reaction was also present. According to the Lauren classification, this tumor is of the mixed type, displaying characteristics of both intestinal and diffuse patterns. The histologic grade was assessed as grade 3, indicating poor differentiation. Both lymphatic and nerve involvement were detected, signaling aggressive disease. The cancer had extended to the serosal surface, which is the outermost layer of the stomach. All examined margins, including the radial margin at the omentum, were free of cancer. Lymph node assessment and staging. A total of 32 lymph nodes were evaluated. Of these, 12 out of 20 perigastric lymph nodes and 3 out of 12 separate regional lymph nodes contained metastatic cancer, resulting in 15 lymph nodes with evidence of spread. The pathologic staging was determined according to the 8th edition of the American Joint Committee on Cancer Guidelines. The tumor was classified as having invaded the serosal surface, and there was metastasis to more than 16 regional lymph nodes, defining it as stage 3. Category B. The assessment of distant metastasis was not applicable and requires further clinical or radiologic investigation. Ancillary studies and biomarker profile. Additional studies were conducted to evaluate molecular markers. The tumor was found to be proficient in mismatch repair proteins, with intact expression of MLH1, PMS2, MSH2, and MSH6. The human epidermal growth factor receptor 2 status was negative, with a score of 1+. The combined positive score for programmed death ligand 1 was 10. Testing for Epstein-Barr virus was negative. Summary of key findings. To summarize, this report describes an invasive adenocarcinoma of the stomach, displaying both gland-forming and diffuse features. The tumor is located in the antrum and measures 5.5 centimeters. It is poorly differentiated and has penetrated the serosal surface. Both lymphatic and nerve invasion are present, highlighting the aggressive nature of the disease. All surgical margins are clear of cancer. 15 out of 32 lymph nodes show evidence of metastatic disease, and the cancer is staged as advanced, specifically stage 3. Category B. Biomarker analysis reveals mismatch repair proficiency, a negative human epidermal growth factor receptor 2 status, a moderate programmed death ligand 1 score, and absence of Epstein-Barr virus. Explanation of key pathology components. Let us take a moment to explain some of the key elements that are crucial for understanding and managing gastric cancer. Histologic type and Lauren classification. Adenocarcinoma is the predominant type of stomach cancer, accounting for more than 90% of cases. The Lauren classification divides tumors into intestinal and diffuse types, each with distinct epidemiological and behavioral traits. Intestinal type forms gland-like structures and is frequently associated with older age and environmental factors such as Helicobacter pylori infection. Diffuse type consists of infiltrating, non-cohesive cells, including signet ring cells, and tends to be more aggressive, often affecting younger individuals with a hereditary component. Mixed type, as seen in this case, shows features of both. Tumor extension. The depth of invasion is categorized from T1 to T4. In this case, the tumor has invaded the serosal surface, a significant risk factor for spread within the abdomen. Lymph node status. The number of lymph nodes involved is a key prognostic indicator. With more than 16 nodes affected, the classification is category N3B, signifying a poorer outlook. Lymphovascular and perineural invasion. Both findings indicate a greater risk of recurrence and metastasis and are markers of aggressive disease. Biomarkers. Human epidermal growth factor receptor 2 status and mismatch repair proficiency guide targeted therapy and immunotherapy options. A positive programmed death ligand 1 score suggests potential benefit from immunotherapy, while Epstein-Barr virus status defines a unique subgroup of gastric cancer. Clinical implications. This detailed pathology report provides essential information for the oncology team to determine prognosis and select the most appropriate post-operative treatments. For a tumor classified as stage 3, category B, post-operative chemotherapy, and often chemoradiation, are recommended. The biomarker profile is especially important for planning further therapy in the event of recurrence or metastatic disease. Thank you for joining us on this deep dive into the pathology of gastric cancer. If you found this episode informative, please consider liking, sharing, and subscribing to our podcast for more content that explores the extraordinary world of surgery and medicine.